It's indeed a pleasure for me to introduce this exemplary person who has followed basically in my father's footsteps of the African diaspora giving back to Africa. So for me, it is a distinct honor. Dr. Parham completed medical school in 1981 at the University of Alabama School of Medicine and was the first African-American to complete a residency in obstetrics and gynecology at that university. He then pursued studies in female urogynecology at the University of London, England, and the University of Khartoum, Sudan, where he studied surgical techniques to repair pelvic defects in women who suffered genital mutilation. In 1988, he completed a fellowship in gynecologic oncology at the University of California, Irvine. He is the founder of the Cervical Cancer Prevention Program in Zambia and the African Center of Excellence for Women's Cancer Control. He is professor of gynecologic oncology in the Department of Obstetrics and Gynecology. I know why Mel asked me to do this. He couldn't repeat all this gynecologic oncology. At the University of North Carolina, Chapel Hill. In Lusaka, Zambia, where he has lived and worked for the past decade, he's an honorary professor of gynecological oncology in the University of Zambia's Department of Obstetrics and Gynecology. The cervical cancer prevention program in Zambia has helped shift the paradigm of cervical cancer prevention in low and middle income countries. Prior to its implementation in 2006, only 10,000 women in Zambia had ever been screened for cervical cancer. Presently, over 500,000 women have been screened. 60,000 are presently being screened each year, and over 40,000 have been treated for pre-cancer and cancer through a nationwide network of government-owned and operated facilities. As a result of its absorption into the Ministry of Health in 2015, the cervical cancer prevention program in Zambia has now been institutionalized as the country's national cervical cancer prevention program, combining a simple method of cervical cancer prevention in which specially trained nurses use table vinegar, cotton swabs, and telemedicine, working side by side with government officials, village chiefs, traditional healers as local advocates, and don't run down the traditional healers. Where's that lady? Abiola, don't run down the traditional healers. The program is now the largest of its type in the world, as has been described by the Office of the US Global AIDS Coordinator as the best system for cervical cancer prevention in Africa. What once was a hidden shame is now openly discussed among women. No longer are they afraid to seek help. Presently, he's working to build and scale up gynecologic oncology surgical capacity in the African region. Congratulations, sir, and I thank you so much for the work that you have done and continue to do.
I want to say a few words. Okay.
Bishop first and Ward second. Make sure you put that Harvard in there. Julius, why don't you put your hand on that? And,
Thank you. With that, I had some slides. Thank you so much for the award. Thank you, Will, for bending to his lobbying. I'm happy to be here. I'm proud to be here. I'm honored to be here. To me, as a cancer physician, I think other than when your patients tell you thanks, the next greatest accolade that you can get is when your peers tell you thanks. So that really says it for me. I'm actually especially touched this night by the opportunity to meet and surprisingly have this award presented to me, not only by the great Melvin Foote, whom I've read so much about over the years, but the son of the late, great Marcus Garvey, Julius Garvey, Marcus Garvey, the great world Pan-Africanist. When I was 18 years old and left, had recently, 3 years earlier, had been jailed in Birmingham for marching with the Children's Crusade in 1963 to fight against racial apartheid in Birmingham. I was in college at Oberlin, and this was when they really had books and the libraries were real libraries, and you could walk through the stacks. And I had been beaten up pretty bad down in Birmingham as a child, as you can imagine, in the 50s, 40s, and 50s and 60s. And I was walking late one night down a row of books, and a group of books said, "Stop, come here, come look at us." And I started pulling these books off the shelf, and they were books by W.B. Du Bois and Sylvester Williams and George Patmore, and lastly, the great Marcus Garvey. And I remember two things that I read in Garvey's book, The Philosophy and Opinions of Marcus Garvey, that really changed my life. One said, "Emancipate yourselves from mental slavery. None but ourselves can free our minds." And the next one was, "A people without the knowledge of their past, history, and origin is like a tree without a root." As I read these books and read more books about the liberation movements going on in Africa in the 60s, I made a decision then in 1966 that one day I was going to go back to Africa and make a contribution. It took me 40 years to get back there, but I never gave up that thought. In 2006, I moved back, and I've been there since that time. But it was reading your father's book, that channeling your father, that got me back to Africa. So it is absolutely something deeply spiritual about this evening, that you would be the one to give me this award. I can't explain it, but I know it's deeply spiritual. As you said, it's a mystic revelation going on somewhere, as Bob Marley would say. So I just want to say a few things about how do I do this? Technology. I may have been in Africa too long. Where do I point? Okay. So I want to talk about just a few words, catalyzing action against Africa's silent tragedy, because this is what I've been doing with a small group of people. Doesn't take a large number of people. As V.I. Lenin said, better fewer, but better. Catalyzing action against Africa's silent tragedy. So what is Africa's silent tragedy? In Africa, women's cancers, which are cancers of the cervix and breast, are not just diseases, but tragedies. Tragedies played out in what I call the theaters of silence that are located in the informal settlement squatter camps in rural villages where women have absolutely no voice, and where the prevailing belief is that cancer is a disease of shame, often associated with the fatalistic curse for having maybe lived an immoral life or some form of witchcraft. So what are the circumstances there? By 2030, the WHO predicts that 1 million Africans will die each year from cancer, and a significant majority will be women who die from cancer of the cervix and breast. The vast majority will die without ever being diagnosed and without any form of conventional medical treatment or access to pain medicine. So what is this catalytic agent that we helped create, that we've been trying to use to fight against this silent tragedy. It's called the Friends of Africa, which was an NGO that we started back in the 80s. And it believes in quadrangular partnerships. That is, partnering with Western institutions such as universities and institutions from low and middle income countries like cancer hospitals and NGOs, and that's some of the ones we've been working with, and also members of the African diaspora. And I guess if we believe genomics, we're all members of the African diaspora. To carry out this mission, that is to decrease deaths from cervical and breast cancer in Africa through the following 4 ways: knowledge transfer, local infrastructure development, facilitating access to cancer care, and research. Again, a small group of people who decided to act, not just to plan, but to act and to figure the rest of it out on the go. Knowledge transfer that we've been involved in can look like this. It can look like mentoring breast cancer surgeons and young gynecologists in Africa at the operating room table, which is what we do. It can be hands-on breast ultrasound seminars. You see one of our physicians from the University of Arkansas, Dr. Rhonda Tillman, teaching a group of Congolese how to perform breast ultrasound. But it can also mean this, and I'm speaking to my young sister in the back, who had so many interesting things to say about traditional social infrastructures in Africa, which is a rich resource that we need to tap into because they are more influential than anybody else in that society. If you read the history of the continent, you'll understand why. So part of the knowledge transfer is educating village chiefs and traditional marriage counselors and traditional healers who will give you then access to the target population. And as the gentleman said today, people listen to people who look like them and who are of their village. So this is the way that one of the ways to get to the target population within the African chiefdoms, because still in the continent of Africa, large number of people still live within the African kingdom concept. But it is also to take money and to invest in local infrastructure. You can't go into a place and start trying to build cancer care if you don't invest money into things that are missing, such as microscopes and laboratories and surgical supplies and ultrasounds and various objects. But at the end of the day, you got to facilitate access to care. And how do you do that? It's not one single way. That's what we learned. It can be in the form of finding hospitals and partnering hospitals to develop hospital-based clinics. When you go out into the rural areas, it can take the form of rural outreach camps. You can have large outreach events. This is one we had in Kinshasa at Dikembe's hospital, where the first week, 8,000 women pitched up. We were only able to screen 3,000, but 8,000 pitched up the first week. Or you can have pop-up clinics where you can put the thing on a truck and take it anywhere and roll it out. Research is important. It allows you to reflect, but it allows you to learn. It allows you to read and allows you to create new ideas and new knowledge. And these are just some of the research projects that we've been able to get funded. The one at the top I really like, because we're now trying to figure out how to use virtual reality simulation to more rapidly transfer knowledge to surgeons to see if that can train African surgeons to perform complex surgical procedures more rapidly than traditional training. And that's funded by the Medical Research Council in the UK. So what are some of the impact we've had in the 3 countries where we worked so far? Zambia, DRC, and Malawi. As Melvin said, we scaled up cervical cancer screening in Zambia between 2006 and 2016. And those are the numbers. And on the red map is what we had in 2006, 1 clinic. And now we have clinics all over the country, and the government said, I want that program. I'm going to make it mine. Trust me, it was not that nice and not that pretty. But, you know, when you have something that's good and that's big, a bigger thing is going to come in and absorb it. So it was a great thing. We also catalyzed the launch of the HPV vaccination in Zambia. This was the first little girl to get vaccinated in Zambia. Her mother was a tribal chief. Her grandmother was a tribal chief. That hit the front page of the newspaper and helped that vaccine to get accepted. Later this year, the Global Alliance for Vaccine and Immunology, Garvey, is going to fund national HPV vaccination of all young girls in Zambia from age 9 to 14. It's going to be a national rollout. But we catalyzed this back in 2013. We've also been able to expand access to cancer care in the DRC. In Dikembe's hospital, we were able to find some money and build breast and cervical cancer early detection clinics and breast and cervical cancer surgery units. This is just an example of the screening, the numbers of women who've been screened in this hospital from July 16 to March 2018. This is the largest number that we know of women who have been screened for cervical cancer in the DRC, and the numbers are increasing. And this is led by nurses who were trained by Zambian nurses. So we believe in South-to-South collaboration. The breast cancer early detection at Dikembe's hospital, since April 2017, the surgeons that we've trained have been able to evaluate 944 women, and they use clinical breast exam and ultrasound. Most women can't pay for the biopsies. They can't pay for the pathology, but these are the numbers that we have so far. But we can use these gaps and these problems to lobby for more resources for the government and for other donors to put the infrastructure in place. Sometimes you got to start with what you have and use that information to lobby for more. And we expanded surgical oncology capacity. We have no belief, we don't believe that we can go into a country and within a year's time train a full-fledged surgical oncologist or GYN oncologist. But we can find the target diseases, the diseases that are killing most people, and figure out a way to train African surgeons to perform a limited repertoire of surgical oncology procedures using the high volume of cases that they have. So we have 2 surgeons, gynecologists in Zambia, and 2 in the DRC, and 1 in Malawi that can perform this complex surgical procedure for cervical cancer called a radical abdominal hysterectomy that usually takes 4 years for someone in the United States to learn. We've trained them how to do it in a year. And we've also trained general surgeons, 1 in Zambia, 2 in the DRC, to do proper modified radical mastectomies. We also have been able to create a global health research experience for the next generation. This young lady is an African-American OBGYN who has been working with us in Zambia for the last 2 years. Because of the work she did and the papers she wrote, she was able to get a GYN oncology fellowship. And so she left last month and went out to the University of Washington in Seattle. And hopefully in 3 or 4 years, she'll return, but this is her research group. So thank you again. Thank you, Brother Julius. Thank you, Brother Melvin. And again, thank you, Will, for relenting. And thank all of you.